Good morning, everyone. I'm excited to welcome you to today's presentation. Today, we'll be exploring signs, symptoms, and abnormal clinical findings. This is a crucial topic for understanding how to identify and interpret various clinical indicators. Over the next few slides, we'll cover key signs and symptoms, as well as abnormal findings that can help in diagnosis and treatment. Let's get started. Let's start by understanding what a sign is. A sign is essentially objective evidence of disease, something that a physician can observe and verify. For example, erythema, which is redness of the skin, or edema, which is swelling, are classic signs that can be seen and measured. These signs help us identify and assess the presence of a disease objectively. Now, on the other hand, we have symptoms. Symptoms are subjective. They're what the patient reports feeling or experiencing. These are not something a doctor can directly observe but are crucial for diagnosis. For instance, burning micturition or pain are symptoms that the patient describes based on their personal experience. Understanding the difference between signs and symptoms is fundamental because it influences how we approach diagnosis and treatment. Signs give us concrete, observable evidence, while symptoms provide insights into the patient's personal experience. Both are essential pieces of the puzzle in clinical practice. When should we consider using R code in our diagnostic process? Well, first, when no more specific diagnosis can be made after thorough investigation. Sometimes, the signs and symptoms present at the initial encounter might be transient, or perhaps we just can't determine a clear cause. In such cases, R can help us explore the data further. Another situation is when a patient doesn't return for follow-up, leaving us with only a provisional diagnosis. Here, R can assist in analyzing available information to refine our understanding. If a case is referred elsewhere before a definitive diagnosis is established, R can help synthesize the data we have. Also, when a more precise diagnosis isn't available for any other reason, R provides tools to delve deeper into the data for insights. Lastly, sometimes certain symptoms pose significant problems in medical care, and it might be useful to classify them separately from the known causes. In such scenarios, R can help us analyze these symptoms systematically. Overall, these situations highlight the importance of R code as a flexible tool to support our decision-making when traditional methods reach their limits. Let's talk about some general guidelines when it comes to using symptom codes. First, it's important to remember that codes describing symptoms and signs are acceptable for reporting purposes, especially when a definitive diagnosis hasn't been confirmed by the provider yet. This allows us to document patient conditions even if we don't have a final diagnosis. Next, we can also report symptom codes alongside a definitive diagnosis code. But here's the key point. If the sign or symptom isn't routinely associated with that diagnosis, say, in the case of complex syndromes, you can report both. Just make sure the definitive diagnosis code is sequenced before the symptom code. This sequencing clarifies that the main condition is the primary focus, with symptoms supporting the overall picture. These guidelines help ensure accurate and thorough coding, which is essential for proper documentation, billing, and statistical data. They tie into our overall theme of precise and compliant coding practices, ultimately supporting better patient care and administrative accuracy. Let's talk about combination codes that include symptoms. In ICD 10-CM, you'll find several codes designed to identify both the main diagnosis and the common symptoms associated with that diagnosis. These combination codes are really helpful because they allow us to capture a more complete picture of the patient's condition without having to assign multiple codes. When you choose one of these combination codes, it's important to remember that you shouldn't assign an additional code specifically for the symptoms. This streamlines the coding process and ensures accuracy in reporting. Understanding how these codes work is key to proper documentation and billing, and it ties into our overall goal of precise and efficient coding practices. Let's talk about repeated falls. When a patient has recently fallen and we're investigating the reason, we use code R296, which is for repeated falls. This helps us document that the fall has just occurred and is part of the ongoing assessment. Now, if a patient has a history of falling in the past and is considered at risk for future falls, we use a different code, Z9181, which indicates a history of falling. This is important because it highlights the patient's ongoing risk, even if they haven't fallen recently. And here's a key point to remember. When both situations apply, say a patient just fell and also has a history of previous falls, it's appropriate to assign both codes, R296 and Z9181, together. Understanding these codes helps us accurately document patient risk and history, which is essential for proper care and risk management. It connects directly to our overall goal of preventing falls and improving patient safety. Let's talk about the COMA scale and how it is used in clinical coding. The COMA scale codes, which are in the R42 range, can actually be used alongside codes for traumatic brain injury, acute cerebrovascular disease, or the sequelae of cerebrovascular disease. This means that when documenting a patient's condition, these codes can be combined to give a more comprehensive picture of their neurological status. Now, an important point to remember is that if the underlying cause of the coma isn't known, or if it's due to a traumatic brain injury, but the COMA scale hasn't been documented in the medical record, then you should assign code R4020, which stands for unspecified coma. This helps ensure that the coding accurately reflects the available information and the clinical scenario. Overall, understanding how to properly use these COMA scale codes in conjunction with other neurological conditions is essential for precise documentation and billing, and it ties into our broader goal of accurate and complete medical coding. When it comes to coding the COMA scale, it's important to remember that these codes should be sequenced after the diagnosis code or codes. So, for example, if a patient has a traumatic brain injury, the COMA scale codes should come right after those injury codes. This helps to clearly link the coma assessment to the specific injury or condition. However, it's crucial to note that these coma scale codes cannot be used together with the code R42A, which is for non-traumatic coma due to an underlying condition. Essentially, if the coma is caused by trauma, you use the coma scale codes. If it's non-traumatic, indicated by R42A, then you don't use the scale codes. Another key point is that these codes are made up of multiple parts, one from each subcategory, so you'll need to include at least one code from each to accurately complete the scale. And, importantly, the 7th character in each code indicates when the scale was recorded, so you need to make sure that all 3 codes have the same 7th character to reflect the same point in time. By following these sequencing and coding rules, we ensure accurate documentation that aligns with the clinical picture and supports proper billing and data analysis. This consistency is vital for maintaining clarity and precision in coding practices. Now, let's look at how to properly assign the code R4024, which refers to the Glasgow Coma Scale, when only the total score is documented in the medical record. The key point here is that if the provider only notes the total score without breaking down the individual components, like eye opening, verbal response, and motor response, you should still assign the code R4024. This code specifically indicates that only the total Glasgow Coma Scale score is documented, not the individual scores. Recognizing this helps ensure accurate coding and avoids unnecessary errors. Remember, the overall theme here is the importance of precise documentation, which directly impacts coding accuracy and ultimately proper billing and medical record integrity. Let's talk about functional quadriplegia, which is coded as R532. This condition refers to the inability to use one's limbs or to walk, and the key here is that it's due to extreme debility or weakness, rather than any neurological injury. It's important to emphasize that this code is not used when the quadriplegia is caused by nerve or spinal cord damage. That's a different situation, and you'd use a different code for neurologic quadriplegia. Also, remember that we should only assign code R532 if the medical record specifically documents functional quadriplegia. If it's not clearly documented, we shouldn't use this code. So, in summary, this code helps us capture cases where the patient's inability to move is due to overall weakness, not nerve injury, and the documentation must be explicit. This distinction is crucial for accurate coding and appropriate patient management. Now, let's discuss SIRS due to non-infectious processes. The systemic inflammatory response syndrome, or SIRS, can actually develop from various non-infectious causes. For example, conditions like trauma, malignant neoplasms, or pancreatitis can trigger SIRS even when there's no infection involved. It's important to note that if no infection is documented, we still need to code the underlying condition, such as an injury or other non-infectious cause. After coding the primary condition, we then assign code R6510 for SIRS of non-infectious origin without acute organ dysfunction. If, however, there is acute organ dysfunction associated with the SIRS, then we use code R6511. In that case, we also need to assign the proper organ failure code to reflect the specific organ involved. This distinction is crucial because it helps accurately capture the severity and nature of the patient's condition. Understanding these coding nuances enables us to better document the clinical picture and ensure appropriate treatment and reimbursement. So, in summary, whether SIRS is without or with organ dysfunction, proper coding reflects the underlying cause and the clinical severity. Now, let's talk about the code R99, which stands for Ill-Defined and Unknown Cause of Mortality. This code is used in very specific situations. It applies when a patient has already died and they are brought into an emergency department or another healthcare facility. In these cases, if the patient is pronounced dead upon arrival, we use this code. It's important to note that R99 does not indicate the discharge disposition of death. Instead, it reflects the circumstance of the patient being found or arriving deceased, but it doesn't specify the cause of death. This highlights the importance of accurate coding and understanding the context around the death. It helps ensure the data we collect is precise and meaningful, especially when we're dealing with cases where the cause isn't clearly identified at the time of death. So, in summary, R99 is a very limited code, meant only for those very specific situations where death is pronounced upon arrival and the cause remains unknown or ill-defined. Now, let's talk about the NIHSS stroke scale. The NIH stroke scale, which is coded as R297, is a valuable tool that we can use alongside the acute stroke codes, like I-63. Its primary purpose is to help us assess the patient's neurological status and determine the severity of the stroke. This information is crucial because it guides our treatment decisions and helps us monitor progress over time. It's important to remember that the stroke scale codes should be sequenced right after the acute stroke diagnosis codes. This sequencing ensures that the documentation accurately reflects the clinical picture, from diagnosis to severity assessment. By integrating the NIHSS into our coding process, we're better equipped to capture the full scope of the patient's condition, which ultimately supports more tailored and effective care. This step is a key part of the overall process of managing stroke patients comprehensively, from initial assessment through recovery.